Today, my name is McPherson, and I'm on talk speaking today on behalf of the Center for Behavioral Health Improvement and Solutions at the University of South Florida. Our guest today is discussing a very important topic on the experience of being a consumer of behavioral health as well as a parent of a behavioral health child. So I'm introducing to you Patrick Hendry, who is the Vice President of Peer Advocacy Support and Services for Mental Health America. He has experienced life with the psychiatric diagnosis, both personally and as a parent of a child with lived experience. Patrick provides national advocacy and develops new services and training for peers within the behavioral health system. That being said, Patrick, so one of my first questions, we know that individuals with disability, and especially with psychiatric disabilities, are among the poorest in our society. Having the diagnosis of a behavioral health entails a lot of issues, and poverty is one of them. How do you see that from your experience as a consumer of behavioral health services? How have you experienced this poverty trap?
You know, it is so gradual, the process for most people, unless you become ill at a very young age, and then you're already trapped because you have no work experience, all this. My personal story was I was able to maintain a career for a number of years and then became very ill and ended up on Social Security disability income and not working. And I was very lucky in one of my hospitalizations to meet a group of peers. We didn't even use that word at that time, but people who had lived experience like I did, who told me that there was more to life than just this very narrow world that I was falling into. And so I began to attend this drop-in center in Naples, Florida, and eventually the group of us got together and we worked with the Mental Health Association of Southwest Florida. They had the contract from the state to run it, and they turned it over to a nonprofit that we created. So I spent a number of years working with people who really are in the deep end of mental health services. You know, there's so many things that happen to you when you become ill, and a lot of it is about losses. Frequently, you know, we lose our jobs if we have them. We frequently lose our friends, and sometimes that's because our friends have discriminatory attitudes about people with mental illness, or because of our own symptoms, maybe push people away. We sometimes lose our family for those very same reasons. And so we don't have the supports that we would normally have, and we find ourselves adrift in this very impersonal system of care that we have across the country. One of the things that happens for so many people, because many of the illnesses that make up serious mental illness diagnoses start early. And so a lot of people don't get enough work experience to even get Social Security disability income. And they end up with SSI, Social Security supplemental income. The big difference is not the money, because you can come close and you can even be dual eligible and get a little from both of them. But the big difference is in the SSI world, you end up with Medicaid. And with Medicaid, you're pretty much going to always be in the public system of care. And the public system of care is way overworked. There are way too many people. I know in Florida, for instance, we only serve about 48% of the people who need services because we can't. And it's constantly growing. Over 50% of the people on SSI with a disability in the United States, over 50% are because they have a mental health disorder or disability. And with SSDI, even 35%. So we're the largest group of people that are disabled by some type of condition that we live with. And now we fall into this trap. And the trap is Medicaid and Medicare, but mainly Medicaid, is absolutely necessary when you don't have a job and you don't have health care, and you live in areas where public health care is frequently not very good, especially if you go outside of behavioral health and you're just trying to get your normal health care services. And so people need that Medicaid. And the benefit right now, the federal benefit for SSI is $794 a month. And you think about that, to live on $7,900 a month is virtually impossible. And you are also limited to the amount of assets you can have, like you cannot own or have any assets over a total of $2,000 for an individual. And then any income that you might receive, even if say your parents provide you with a place to live, that's counted against you for your SSI benefit. And so are, gifts even. You're supposed to report gifts that you receive and any free food that you receive. The only thing that you can receive that's excluded from that is a public benefit. So if you're in a housing program, it's not counted against you. If you're in food stamps, for instance, that's not counted against you. But this makes, our work much harder. I mean, public housing for people with disabilities, the waiting lists are years long to get into good housing. Some people get lucky and get into some kind of specialized housing program, but they end up living in our society on the way below the poverty level. The income is about $9,200, $9,600 a year, and the poverty level is like $12,000 a year, I think, and that's and that's very low. I mean, how can you? Poverty level, according to the federal government, is based on the amount of money you need to meet your needs in society, living in the community. And so when you're below the poverty level, you don't have enough money to meet your needs. So people end up not being able to do much with their lives other than just exist. And because of the attitudes about mental illness in our country and frankly, in the Western world in general, there's a lot of discrimination against people with a diagnosis, people with a history of hospitalizations and all of that. Some people refer to it as stigma. I tend to think of it more as discrimination, because it's based on the attitude of the individual who's acting that way, and not anything about me as an individual because I have a diagnosis. But that further pushes us to the edges of society. And the consequences of social exclusion are huge. People, when they are excluded, when people are socially isolated, and we're seeing so much more of that during this pandemic.
Yes.
The consequences affect every part of your life. They affect your health in almost every aspect. Longevity, heart disease, cancer rates, every kind of condition you might have is made worse for people who are lonely, feel excluded, and don't have those kind of just social supports that we need as human beings. I mean, humans are social creatures. We're supposed to be able to talk to each other. So the only answer to that then is to go into this world of consumers or peers. And so you live in a kind of little bubble of society, like the drop-in center I was referring to. Everybody there was somebody with a diagnosis. Now, I was really lucky because there were some very progressive people there who said, you're not stuck here, you can get out of this trap. And they kept encouraging me to do that. And I was able to do it. I was on SSDI for, I believe it was 9 years. And then I returned to work. And I returned to work almost immediately full time. And I've been working 25 years since that time. But that's unusual. I was on the SSDI side, so I was allowed to keep my Medicare for 7 years. On the SSI side, there are some programs that will allow you to keep Medicaid, but they're very complicated. And our system of care does not do a good job of educating people about what's really available to them. So we have people living in fear of losing this $794 a month, losing Medicaid, and consequently they have, they have no money for social activities. They can't even go and meet their friends at a McDonald's and have a hamburger and a milkshake most of the time because they're so poor. Now, frequently, families will help people in different ways, but that's actually not allowed in the system that we've built. We need to totally rethink this.
Absolutely.
We need to figure out how do we support people, because if we support them and we give them some degree of quality of life, the chances that they will do better, that they will move into recovery and begin to have meaningful things in their life again are greatly increased. And when we separate them and push them away to the edges, we are almost dooming people to stay in that. There's been some changes, and they're kind of generational. The older people, I would say people in their 40s and up, came through a system where a lot of this information just wasn't available, and even the rules were more strict when they first came into it. And so even though the rules maybe have loosened up a little, they've lived under those rules, and they still do. And in the peer world, we refer to that as the deep end of services, where you're just really caught in something you can't get out. Younger people are learning a bit more about the system now. It's being explained to them a bit earlier, but we still experience this thing that when you're first diagnosed with a major diagnosis, the message you get is you have a mental illness. You're always going to have a mental illness. You have to take medication. You're always going to have to take medication. You'll probably never work again, or if you do, it's going to have to be something very simple and low stress. That's a message of hopelessness.
Correct. Yeah, I agree.
And when people are hopeless, they stop trying to change their lives.
Patrick, tell me, like, for example, if a person is on SSI or SSDI, are they allowed to earn a certain level of income at all to supplement that meager $794 a month?
And even that's complicated, but yes, they are. So for instance, if you're receiving the $794 and you start to go back to work, you could actually earn up to about $1,600 a month. But what happens is the first $20 you get, they don't count against you. The first $65 you earn income from work, they don't count against you. After that, they take half of every dollar you earn off of your Social Security benefit. So if you go back to work, and most people have to go back very gradually, so they may start off working 10 hours a week, 20 hours a week, and then they can't get private health care because they're part-time workers, so they're still in that Medicaid trap. And as they go back to work, they maybe earn, let's say they earn $1,600. Well, if they do, and you take out that $20 and that $65, your income is $1,515. Now, half of that is $757.50. Your benefit is $794. So you end up with about $36.50 left in your benefit. The key to it, though, is that you only have to have $1 of benefit to stay on Medicaid. And so you can conceivably work up to that. But if you want to stay on Medicaid, you can never earn more than that amount that we're talking about, a little bit over $1,600 a month. So even that is just, a little bit above poverty level. And that's that message that you were given, if you're going to work, it's going to have to be this and this and this. Well, that's where it comes true for so many people. There are programs, there's Ticket to Work there that allows you to go back to work, and there's Medicaid buy-in programs where you can go back to work and you can pay to keep Medicaid as a service. You're allowed to, for instance, exclude money that you need to accommodate your disability. So it might be, if you had a physical disability, it might be a modification on a vehicle that you were driving, or if you have a mental health, diagnosis, it might be, because you're living in poverty, you may have to take buses to work every day. You can exclude those things. So there are these paths to get back, but most people don't understand them.
And it's complicated to access, very complicated to access.
Everybody who encounters Medicaid, their Medicaid rules, including doctors, the rules are just so complicated and so twisted, and they keep adding little bits every year that don't necessarily make sense with the other bits. So it just becomes this system of confusion, and unfortunately, we get stuck.
Yes, and disincentive too, as well, So it's, how would you say Florida stacks up in comparison to other states? Are we doing a better job answering the needs of consumers with behavioral health issues, or are we in the middle, or is it pretty much the same all over the country? It's kind of chaotic.
Well, a number of groups, including Mental Health America, looks at states and the services they provide and the number of people they serve and the amount of dollars they spend. Florida ranks in the bottom half. Now, at times, it's been way down towards the bottom. Lately, it's been a little more closer to the middle, but still in the bottom half. Florida has never been really big on spending money on social services of any kind. Housing is a huge problem in Florida, especially now because housing rates are going up so rapidly. And again, if you want to get into federally funded public housing, you might have to wait anywhere from 2 to 4 years to get into that. So if you're lucky enough to receive services, say from a community mental health center that has a supported housing program, they might be able to help you get housing. Or if you're very ill, if you're an individual who's had many, many hospitalizations, and still having really active symptoms, you might end up in what's called assertive community treatment teams, ACT model, which comes with housing programs. So this is where people who normally would not be able to live in the community unless it was in a really bad neighborhood and, really everything would be against them for success to improve, to move into recovery. So programs like ACT and supported housing and supportive housing, they offer opportunities for people to move up a little bit in that notch, maybe live in a little bit better place with a little bit better access to food. Some people live in poverty. They don't have even access to good food, even if they had the money, because poor neighborhoods tend to have fewer grocery stores. They're frequently referred to as food deserts. So all of these, it's just so complicated, Marie. It's like every direction you look, there's another blockade.
Right. If the barriers appear to be not only many, but in many cases insurmountable. And it's a sort of ironic that to get better services, you have to be sicker.
Yeah, it is. And then even still, we don't have a really good success rate, particularly with older people who maybe were diagnosed when they were 18 years old, and now, if they were my age now, they're stuck and they've lived their whole life from 18. I'm 71 years old, and they've lived a life of poverty. They lived a life of social exclusion. Their whole world is centered around the fact that they have a mental health diagnosis. Frequently, all of their friends are people who also have that. I have a son who is 42 years old, and he was diagnosed with bipolar disorder, as I am, when he was 12. I wasn't diagnosed until I was 35, but I had symptoms. I just wasn't diagnosed. But he was diagnosed very early, and he kind of got a hold of it, and we worked together, and he was able to build a career. And he had a very good job. He made really good money, much more than I did. And then he started having symptoms again, and he ended up in crisis, and he ended up losing his job. He ended up losing the house that he owned. He ended up losing his marriage. He ended up losing most of his friends, and he fell into that pit. And it's taken him now 7 years to come back out of it again. Now he's going back to work. He's starting to work in a field that he's very knowledgeable about. He's in IT, and he's very skilled in that area. So he's got a fairly decent job. He still has symptoms, but he's managing them because the work gives him a feeling of self-worth. Mm-hmm. And that's one of the things we're denying people. Think about it. How do Americans identify themselves? You go to a party, what's the first question?
What do you do?
What do you do? Exactly. Yes. That's who we are to a large degree. We're our family and we're our job for the most part. Mm-hmm. And so when you lose and you can lose both of those, but when you lose that identity, you lose your sense of self-respect too. And so everything is kind of working against you. Quality of life just goes down so much. So I watch my son Dave as he's making this comeback, and he's rebuilding that sense of self-respect. It's still very tenuous. He'll call me maybe today. He called me yesterday in a little bit of a crisis, feeling like he couldn't do his job, even though his bosses are telling him he's doing great. And all that. He doesn't have that confidence back.
The anxiety, yeah.
He feels like he's on a knife's edge. He's right on the edge, and he could fall off one way or the other way. So, and he's lucky because he has me and his mother and my wife now, my wife is a retired therapist. Luckily, she's not my therapist, but she's been able to help Dave also, figure out his way. But most people don't have this kind of support.
Yeah. Which goes comes around for me to think about, so he's very lucky. Your son is lucky. He has you. He has your wife. He has this nurturing environment. But for those who are not as lucky, could we just talk about, from your point of view, and an issue where you have dedicated a large portion of your life, the power of peer support when you do not have that family environment?
When we talk about peer support in mental health or behavioral health, what we mean is individuals who have what we call lived experience with the mental health diagnosis or substance use and addictions. But let's talk just about mental health right now. And so I am referred to as a peer. We've even formalized peer support by creating certifications. Florida has a certification program. People who go through some very specialized training, take a competitive examination, and become certified to work in this field. I told you when I first fell into the whole new world to me, I didn't know anything about mental health. I just was so lucky. I met some people that today I would call peers. At that time, they were just people I met. I didn't know anything about it. But they supported me. They talked to me about what was going on. They told me that hopeless message wasn't true. And so peer support has proved itself tremendously. We have a number of ways peer support is provided. There's over 40,000 certified peer specialists in the country now, 40,000. And California is just starting to get certification. We know they have a minimum of 6,000 already working in that state. So it's rapidly growing, which is wonderful. But we have some programs, for instance, for people maybe who are in a state hospital and they're going to get released, where a peer specialist, a peer support person, goes in and meets them and begins to talk to them about what they want their life to be like when they're discharged. And then through these special programs, that same person follows them into the community and continues to support them for a set amount of time. And it could be 6 months, it could be 3 months, depends on the program you're in. It's called peer bridging. Well, the impact of it is that we have seen that people who receive that kind of services, frequently they've had multiple hospitalizations. And if you look back and take a record of, say, the previous hospitalizations in the previous 2 years, and then you look at the year and the 2 years out after they're released and receiving peer support, rehospitalization rates drop as much as 65%. Total inpatient days in an inpatient facility drop anywhere from the high 30s to 60%. Recidivism in jails, when you do that same kind of program for people with mental health problems who end up in the criminal justice system, the recidivism rate drops dramatically. It's because they have somebody in their life who cares. When I was working in that drop-in center, we were just starting to talk about this word recovery. It wasn't even used in mental health until the late 90s. And so we started to say, okay, well, what do we think is the strongest thing for recovery for us? And we'd send out these surveys, groups all over the country did. And 3 years in a row, the same thing came back as the number one. And that was having at least one person who believed in you, one person who supported you. And for way too many people, that one person is a peer specialist, is a peer support person. But they also receive support by, peer support from the people around them. Support groups are wonderful. I mean, I went to support groups for years, and it not only helped me work through my issues because I had the benefit of everybody else's experience. So I would encounter something that maybe was going to, oh my gosh, the world is going to fall apart. And then I've got this group of people who can say, well, when that happened to me, and then we would have a discussion. And that's peer support. And that's like this group knowledge, and it just continues to grow and grow and grow. We've got peer support now in hospitals, in jails, in prisons, on mobile crisis teams, in community mental health centers, in peer-run programs where it's just one-to-one. I mean, virtually any type of the ACT teams that we have in Florida and all over the United States have a required position of a peer specialist on them. Almost anything you can think of, peer support is beginning to get in there. And each time it does, the services get better.
Would you say that among a sort of a somewhat bleak landscape for mental health, a peer support concept is definitely one of the brighter, really of a wider spots sort of to put emphasis? Is there funding for peer support group to to nurture them, to start peer support in communities? Is there any training or funding available?
The state, when we first created certification in Florida in 2006, I think, the state paid for people to go through the training and to get certified. And then later, as Florida and almost every other state moved their Medicaid programs into managed care where outside companies were doing it, they also encouraged the inclusion of peer support. And so it was paid for. But then around 2009, 2010, when we had the recession, the budgets for peer support were cut dramatically. I mean, they were cut in half or worse. There were, at one point, I was running the Florida Peer Network at that time, which was a statewide network of people with lived experience. And at that time, there were 65 of these drop-in centers, these social centers, these places you could go to learn about your condition and to learn about advocacy. When I came back to Florida, I went away to work for Mental Health America, and I worked up in DC for 6 years. And then I came back about 6 years ago. There were only 30 left of the 65 that had been there 6 years previously. and it's not been restored. Now we're in a really interesting place for peer support. States are in trouble because of the pandemic. Incomes for the states are way down, tax base is way down, sales tax are way down. States are in trouble, and they're going to have trouble meeting the needs. And now the pandemic has created a huge wave of depression and anxiety and made any other kind of mental health condition worse. And we're beginning to see that grow very quickly. And meanwhile, the dollars to provide the services are going down tremendously. We've had all over the country, we've had community mental health centers go out of business, just cease to exist. So peer support, even if you pay people a decent salary, is still a very reasonable, affordable way to provide the support people need until because what we're having is these long waiting periods, long waiting lines to get services. Well, peer support can start almost immediately. And it's a wonderful way to provide support and education and everything else that people need until maybe they can get to see a psychiatrist, or they rarely in community mental health get to see a therapist. We have very few case managers left in public mental health care anymore because of the ways that billing and everything has changed over years. So peer support has to fill in all these gaps. And we're lucky because we have this workforce that's already trained. Many of them had lost their jobs previously because of, really from 2009, the recession, and a lot of it didn't come back. But they're certified, they're trained, they're available, and we're already starting to move into them. The Kennedy Forum, which is put together by Patrick Kennedy, former congressman, part of the Kennedy family, has been proposing the creation of a recovery corps, kind of like the Peace Corps or Job Corps or something. And part of the leading edge of that would be community health workers and peer specialists, trying to meet the needs of people while the rest of the system tries to catch up to the need. You can't quickly train a bunch of doctors. You can't quickly train a bunch of therapists. You can't build those workforces quickly. But community health workers and peer specialists, you can. And so it is growing. In the budget that was put out now, there's $10 million in the federal budget for training. There's over $100 million total for these types of services. So we haven't seen any of that yet. And it's been in the budgets before and didn't come true, but we think it will because the bill that was passed previously in February. So peer support is getting a little bit better funded. Mental Health America, one of the things I've worked to try and do for many years is to get peer support available to the private sector because it's not there. Insurance companies, if you have Blue Cross or Aetna or United or whatever, those policies just don't pay for peer support with just a few exceptions. And part of the reason for that is because the way this system grew, every state has their own qualifications, their own certification. And they will only allow state dollars to be paid to peer specialists who went through their process. And they vary so tremendously. Like there's some states that require 50 hours of previous experience, whereas New York State requires 2,000 hours of previous experience. Some places
require wide variation into the requirement. Wow, that's tough.
Some states require 35 hours of training, for instance, and I think the highest in a state is 110 hours, plus a practicum where you're supervised as you begin to work. So, more like a certification in some other kind of position. So Mental Health America, we did something that nobody did. We wanted, the insurance companies want to know that if they're paying for peer support in Washington State and they're paying for it in Florida, they want to know they're getting the same quality of services. And right now you can't say that. So we created the National Certified Peer Specialist credential, and it's an advanced level. It's for people who are already certified, who are already working.
I see.
And it creates an even level of services across the country. So now some of the insurance companies are starting these pilot programs. We've worked with Kaiser Permanente, we've worked with Aetna. Many of the health insurance companies are starting to make the move into providing peer support. And it's just as important if you're in private services as it is if you're in public. I mean, you still have to go through all those experiences of hospitalizations. And, you know, our system of care, my first experience in the system was being taken in the back of a police car with handcuffs on to a local crisis center.
Sort of a Baker Act type of
It was a Baker Act.
It was a Baker Act, yes.
And that's traumatizing. It's highly traumatizing for some people. And so what we're doing is we're taking very vulnerable people and then we're treating them in a way that just makes it worse. We have to rethink all of this. You know, there's a type of services that are called stepped care, and it's just really beginning in Canada. And there's a center that's just started at Berkeley, UC Berkeley, to kind of rethink the whole system, kind of holistically, so that all those moving parts actually fit together.
Work together, yes, exactly, right. Instead of against each other.
So that's our goal. I don't know that you can ever achieve it, but you certainly can make progress.
That's
and I think peer support plays a really critical role, because one of the things about peer support is you can build trust so much quicker if you're a peer. Like much of my job, even now, and I worked for the state of Florida, I would go into the psychiatric hospitals, I would go into the forensic units where people who had been very violent, and I would sit down and I would want to know about their quality of life and their experience. And the fact that I had had some similar experiences and we could share a little bit, I was able to build trust with them. Whereas if a therapist had walked in the room, immediately there's going to be a little bit of, I don't trust you. You're here to do something to me. I'm not. I'm there to listen to you. I'm there to help you figure out what you want. So it's really a valuable tool. And I can honestly say, Marie, it saved my life. I would not be alive if I hadn't met that group of peers.
So Patrick, if someone wishes to become certified or wants to be a peer support, what's the first step that they should do? How do they find out that information? Do they go, for example, on your website, for example, Mental Health America, and by state, they will be able to find what do they need to do to get certified? You know,
there's actually a SAMHSA-funded Technical Assistance Center, SAMHSA, Substance Abuse and Mental Health Service Administration. And they have funded these technical assistance centers run by peers. I used to run one of them for them, but there's one called Doors to Wellbeing, and they list all of the certification organizations around the country. In Florida, it's called the Florida Certification Board. They're in the process right now changing their name because they actually work in about 10 states. So they're moving towards a more, national name. But the Florida Certification Board is where you go. You can go online, you can look and you can see everything you need to do, and the steps are really clearly written out. They accept certain kinds of training. Where you receive your services would be the first place to go to ask, where can I get my training? How can I get my training? A lot of times, like a mental health provider will make sure that they have some peers who've gone through the training. So they pay for the training. It changes from time to time. Sometimes the state puts it on just across the state. Other times it's managed care is paying for it. And sometimes it's just local provider agencies. But it's there. You might have to wait, 3, 4, 5 months for the next training. In Florida, the training is a minimum of 40 hours, but it's actually much more than that because there's also some whole health training that you go through. So the real training is about 75 hours, I would say, to get certified and employable. There's an examination you have to take, and you need to have done some volunteer work ahead of time. So going into these kind of social centers, drop-in centers, clubhouses, or even working at a community mental health provider agencies and volunteering to do something. It could be a warm line. You could be the person who answers questions on a warm line. To get 50 hours, I think it used to be 100, but I think in Florida right now it's 50 because they're trying to build the workforce up quickly. But you got to get some previous hours, and you got to be able to prove that you did it. So somebody has to say, yes, this person volunteered for us and all that. But the information is not hard to find. And you can find it out in other states too by going through Doors to Wellbeing. There's another group that also offers the same information called Depression Bipolar Support Alliance. They're known as DBSA. They are a national peer-run organization, the oldest and the largest peer-run organization in the country, and they've often done train. In fact, I think they're currently doing some trainings, and they have a model of training that they do, and they know also how people can get certified because they have like support groups in virtually every state, and in Florida, I bet there's 24 locations where DBSA is holding support groups. So
do the support group also sort of function also as sort of a patient navigator in helping people navigate the system? For example, how do they get on SSI or SSDI? Are they also, is this also part of their of the types of help that they can provide, a consumer or a patient?
There's a lot of different kinds of support groups. So some support groups are kind of education based, and maybe they're 90 minutes long once a week, and 30 minutes is talking about about how to get on benefits or some educational topic that can help people, how to find housing, how to get local transportation, where are the local food banks, things like that. Other support groups are just really about how was your week, how are you doing, and then they share information. But peer support, part of being a peer specialist is being a navigator, helping people to learn how to navigate that system, because the system is really complicated. It's just so complicated.
Yeah.
And it changes, and then you have to kind of keep up with what's going on and all that stuff. We don't do a good job formally in providing navigation. We do it better through these informal like support groups and drop-in centers and clubhouses. Clubhouse model is a very organized model. Florida has several of them. They're international, and they have very strict rules, and they're all based around, it's a place you go, and it's not quite as social as, say, a drop-in center or a recovery center. It's based around the idea of work. And so there's different levels of ways to go back into the workforce, and you can go into kind of supported employment, and you can go into competitive employment in your community and still maintain some supports as you need it. But they do many things. There was one up in Clearwater. I think it's still there. I've forgotten the name of it, but a clubhouse. And they had their own little newspaper that they put out all the time with all this kind of information. And they actually had their own television news that people could come and they could watch a news show about changes in the system. And
well, yes.
Now that's going back a ways because I haven't been involved with them in a long time. But yeah, these ideas are all out there. Recovery is an amazing thing because when somebody starts to feel like they're moving into recovery and they're starting to have some control in their life, one of the first impulses is to help somebody else, to give back. the whole idea of peer support is built on a very simple principle that's been used in behavioral health for many years. In fact, it used to be called a therapy. It's the helper principle. And the helper principle is, if I help you, it helps me. And there's been some research done that shows that if I help you, I actually get helped more than you do. So, you know, that's one of our first instincts.
Yes, yeah, system. Yeah, Patrick, just one question that I'm dying to ask you. Now that we have managed care company, you know, managing the state's Medicaid systems, how has their role, how have they been, you know, helpful in, you know, like creating the peer support, clubhouses? How has it get, since managed care came, Medicaid managed care for behavioral health came on the scene, have things improved? Have they been, you know, a source of help?
In general, yes. You know, like Florida has multiple contracts for managed care. I can't remember how many different managed care contracts are here. So, and a lot of states are like that. And then some states have one contract for the whole state. Some of the managed care companies have been really good at promoting recovery concepts, promoting things that make people, you know, feel more involved in the community, providing peer support as part of their services. And then some have not been so good. Some come more from what we kind of call a medical model. It's about, you know, seeing a doctor, being on medication. And that's really, if that's all you give people, that's kind of like maintenance. It's like, okay, we're going to lift you up to this point where you can just maintain, but we're not going to give you anything that helps you move fully back into a life that you'd like to have. That, when we do that, we call it a recovery model. And most states are somewhere between the two, Florida included. But when managed care first was starting in Florida, and I mentioned I was running the Florida Peer Network at that time, we were against it because Medicaid services at that time were fee for service. So if I went to a doctor, that doctor got paid directly by Medicaid just for what I did. So all of the money that was for me went to my services. When managed care came in, it said, okay, we're going to have this company that manages all of that. So that meant they were going to take out a chunk of the money. There would be less money for services. So our first instinct, a lot of us, was, oh no, we don't want that. And we fought very hard. And we were told that there would be these economies of scale and things like that. And so we did some research, actually, and we came up with that the economies of scale would take about 5 years to kick in. And that's how it worked out, actually. After about 5 years, managed care is really doing way better because they do have these economies of scale. And a lot of states have been smart that they required in the contract proposals that people would put into a bid to get the contract, that they write into the contracts peer support. And Florida has done a lot of that. Or the companies have provided peer support. It ebbs and flows, Marie, because the contracts change constantly.
Yes.
There's gone through so many different ones. And some of those companies have been really oriented towards peer support, recovery model, some less so. You know, whoever's making the decision on which contract wins the bid. A lot of times it's all about dollars. But I think in general, yes, it has been a benefit.
But that's very, very good to hear. But in general, you know, are you hopeful about the landscape of behavioral health services? Have you seen, you know, through your long career, you know, things getting better? Are you hopeful?
I am. I think things are getting better. And that's why I was saying there's kind of that generational divide. I think people have come into the system in the last 10 years or so. It's not been as hard to come in. There's still bad things in the system, and we still traumatize people, and depends on the state's rules and all that stuff. But it is getting better. Peer involvement has been a big part of that increase in quality of services. Peer support is looking mainly for one type of outcome. That's that we improve your quality of life. Whereas another program might be looking at, that you stay on your medications. They count how many, whether you go back in a hospital, which is a good thing to count if we can reduce that, because that does improve your quality of life. But peer support is based around quality of life, and systems are getting more oriented that way. When I left Florida in 2009, Florida was using this thing called Recovery Oriented Systems Indicator. It's known as the ROSI, and it was a tool that they used to measure the success of providing public mental health services. And it looked at quality of services and quality of life. And so those are, you want to look at both of those things. And if the system becomes aware enough to do that, it will get better, because it can see, bureaucrats, legislators, everybody who writes the rules, they want to see it in black and white. They want to see numbers. Turning quality of life into numbers was not easy to do.
No, it's not. It's been a challenge. All that I keep hearing. How do you measure improvement in behavioral health? Yeah. What is an improvement? Is it keeping people out of a hospital, of course, or is it, keeping them employed, keeping them, participating in everyday life? That's what I hear a lot. What do you think is an improvement in this arena of behavioral health care? It cannot just be keeping people out of a hospital, right, or medication adherence.
Right. It's all of it. It really is all of it. I'm teaching a class right now for the American Psychiatric Association on how you design a program that includes peer support. How do you measure success? How do you measure outcomes? And we look at it, we do look at hospitalizations and law, the legal system involvement and things like that. But mostly what we look at is, is your quality of life, and the ROSI is one tool that's good at that. There's another one called personal outcome measures that's been around for many years, and it's just 21 things, and if they're there, you give them a 1. If they're not there, you give them a 0. So you can score it numerically, which they, the accountants and everybody love that. So, but it's things like, do you feel like you're treated with respect in the services you receive? Do you feel like you're treated with respect in your community? Do you have friends? Do you have as many friends or opportunities to build new friendships? Do you like where you live? Do you have a choice of where you live? Just like things that are important to everybody. I mean, and if you take those 21 things, nobody would get a perfect score.
No,
if they were honest. Right? So, but it's good because it gives you a numerical number, just like the ROSI and some of the newer tools that have come out in the last 4 or 5 years. So we can measure recovery, the way a person feels about their own recovery. We can look at the medical side of recovery. We can look at the functional side, things like, staying out of jail and stuff like that. And then we can look at, do you feel like your life is moving in a trajectory that you want to? Are you on a path of recovery? And that's it. Because recovery is not a destination, it's a process. It never ends. You just keep moving. But that's true for everyone.
It's true. That's very true. Patrick, well, I want to say, really that over the years you have been an inspiration to all of us in raising awareness, challenging the stigma of mental health, and constantly being a warrior for advocating for the rights of people with behavioral health issues. And for that, we not only applaud you, but thank you enormously for all your work and effort. And I personally am one who is constantly looking at you and what you've written, what you are doing in sort of copying what your expertise as an expert, what you have found and has helped us moving in the right direction. So for that, we are deeply grateful. And thank you so much for agreeing to talk with us this morning. It's been wonderful. Thank you again, Patrick.
Well, thank you, Marie. And I just want to say one thing. There are hundreds of thousands of peers that are all thinking this way, and we have supported each other. And so many of these innovations come from all over the country, and somebody has a good idea, and then maybe somebody like me has a little bit of an opportunity to try it out. And so it's peers. To me, that's the most important.
But also to let everybody know, to have a forum to be able to really communicate what is happening. It's equally important.
Yes.
So
and thank you for the opportunity.
No, thank you, Patrick. Talk to you soon. All right. Bye-bye.